Okay, hello everyone. Today the topic that we're going to discuss is social epidemiology, and we have Dr. Roman Pabayo. Dr. Pabayo has been working in the field for many years with impressive accolades and achievement. And Dr. Pabayo is currently a Canada Research Chair in Social Epidemiology and an assistant professor in the School of Public Health at the University of Alberta. His educational background is also very impressive. Obtained his Bachelor of Science at McMaster, Master of Science at McGill, PhD at University of Montreal, and postdoctoral fellowship at Harvard. So we're going to be talking to Dr. Pabayo about social epidemiology today. Welcome.
Thank you. Thank you for having me. My pleasure.
Yeah, thanks for talking with us. So, do you want to give our students a sense of who you are in any way you want to describe yourself?
Okay. So traditionally I was trained as a traditional sense of in epidemiology. So as you know you know from your lectures, I guess, is that epidemiology is what the study of the distribution, so study analysis of the distribution of so who, when, and where of patterns and determinants of health and disease conditions in defined populations, right?
Mm-hmm.
So basically there are risk factors, there are patterns that are observed when we think about risk factors and the disease. There it's never really random, who gets a disease. There are certain patterns
Mm-hmm.
that we as epidemiologists we try to observe, identify, and then use that data and that information to create interventions and try to make public health um, more healthier and better for everyone, for the whole population. As a social epidemiologist, so when I went to, in Canada, I was trained traditionally. I did a lot of work in my master's and my PhD on nutrition, physical activity, and smoking. These behaviors, these three behaviors. What are predictors? What are risk factors for these behaviors? And when I went to the United States, I worked with Achiro Kawachi, who is a international, world-renowned social epidemiologist. I got more involved with the social aspect of epidemiology. So when I talk about social epidemiology, I'm talking about I study the social determinants of health using an epidemiological perspective. So the
Mm-hmm.
social determinants of health, which has been endorsed by the World Health Organization, is the study of the places and the conditions, or for example, the social conditions in which we are born, grow, live, work, um, and it doesn't just focus on the individual. It focuses. It's more complex, right? It's not just individual choice. It's more about how these conditions influence our health. And also, I think what's missed is that or overlooked is that there is a key aspect of the social determinants of health framework is that there's inequity. Okay, so that not everyone has equal access to social goods. So, for example, the income or power or resources. So some people have better access to social goods, so to education, occupation, money, than other groups. And you could think about, some of these. You could identify some of these. So for example, if we think of a social good as safety, or not having to worry about walking home alone at night.
Mm-hmm.
We know that men are more likely to, or less likely to have, to experience any kind of danger, and that women are more likely to experience that danger. So that inequity there
Mm-hmm.
is sort of what we study in social epidemiology. And I just want to stress also that we look at it in a quantitative manner. So we use statistical analyses, we would call it number crunching, to come up or to help explain what we observe
Mm-hmm.
through data, hard
Mm-hmm.
data.
Mm-hmm. Yeah, and in your description, you have mentioned that we need to provide equitable access to people. And I know that you've done research around, looking at income inequality, racial inequality, gender inequality. So when we talk about equity and equality, like what are the differences and are they related?
Okay, that's a good question.
Mm-hmm.
So the, both describe equity and equality, describe differences or variations in
Mm-hmm.
access to social goods, right?
Mm-hmm. Mm-hmm.
The difference between equity or inequity and inequality is that inequity is due to some sort of bad policy or social
Mm-hmm.
injustice. But these could
Mm,
be prevented.
mm-hmm.
And inequality is more doesn't have to do with some sort of bad policy.
Mm-hmm.
Could be biologic, for example. So, for example, if we look at the COVID outbreak right now,
Mm-hmm.
right,
Mm-hmm.
or a pandemic, we see that older people are more likely to be to experience the adverse effects of getting sick. It's
Mm-hmm.
a lot of times it has to do um, with uh, biologic sort of like because they're older, their immune systems aren't working as well,
Mm-hmm.
right?
Mm-hmm.
And younger people are less likely, right?
Mm-hmm.
So to experience these adverse effects. So, but I also want to point out that inequity and equality, something could be an inequity to one person, could be perceived as an inequity to one person, but it's not perceived as an equity as an
Mm-hmm.
inequity to another person.
Mm-hmm.
So, for example, I just gave the example of the older age,
Mm-hmm.
being biologic,
Mm-hmm.
that it's an inequality. But let's say we know that older people are more likely to live in long-term living facilities, and that there's like policies have been put in place to protect elderly people living in these long-term facilities. So, for example, we know that exposure to people to workers, PSWs, personal support workers, going
Mm-hmm.
from different centers is a driving force or a risk factor for infection, and therefore adverse health outcomes amongst the elderly. If the policies aren't put in place to prevent these infections, then, like, for example, like making sure that PSWs don't work in different centers, etc., then that would be, in my opinion, an inequity because there
Mm-hmm.
are policies that could have been put in place to prevent that.
Mm-hmm.
Um, so that's the difference between inequity and inequality.
Yeah, so I guess the main difference is that equity is something that we can achieve by having equitable policies and programs or equal or equitable allocation of investment
Right.
and resources, whereas equality is something out of our control, and more of the outcome of the equitable policies and programs, would you say?
So uh, yeah, so in terms of inequity, yes, exactly. Like you're right. It
Mm-hmm.
has to do with some sort of bad policy.
Mm-hmm.
Inequality has to do something. It could be random, or it could be due to some
Mm-hmm.
biological function that we cannot prevent through a policy.
Right. So in social epidemiology, looking at those bad policies can be one of the things that social epidemiologists do. So in Canada, do we have any examples of bad policies?
Um, okay. So when
This is non-political conversation.
right. I mean, well, it has to be a political conversation because if
Yeah.
we talk about inequity, we're talking about bad policies or bad
Mm-hmm.
politics that drive the inequities.
Mm-hmm.
So um, there are several. For example, you could talk about the bill in Quebec that bans public servants from wearing religious symbols.
Mm-hmm.
So you're systematically, this policy systematically discriminates against um, people who wear religious symbols, who can no longer um, uh, be employed in positions such as, teachers, daycare teachers,
Mm-hmm.
working as a bus driver, etc.
Mm-hmm.
You're disproportionately limiting them in comparison to people who don't wear these religious symbols.
Mm-hmm.
Um, and so you're limiting their occupational choices, and we know that
Mm-hmm.
occupation is tied to, you know, the social conditions. It is a social
Mm-hmm.
condition in which we are born, grow, etc. Um,
Mm-hmm.
and not alone the impacts of discrimination felt by laws such as this law,
Mm-hmm.
um, that could make a negative impact on mental health, on health overall, etc.
Mm-hmm. Right.
That's
So
one. I mean, it's
yeah.
historically Canada has implemented. There have been lots of laws that discriminate based on religion, race, ethnicity. You have
Mm-hmm.
in the residential schools implemented to the scooped up the indigenous children and strip them of their culture, etc. And that
Mm-hmm.
those negative impacts are still felt today.
Mm-hmm. Yeah, for sure. So, there are researchers such as like yourself working on this area of research and really tackling important health issues and social issues that we have in Canada and also globally. So when you think about, Indigenous health and all the disadvantages that they have as a population group in Canada, and as a social epidemiologist, how do you see it changing in the near future? Because we have been talking about this for a long time, but it hasn't been like we haven't been making a lot of progress. So do you have any comments on that regard?
Well, I think it takes a lot of work, and I don't have that's a very tough. That's actually a very tough question to answer
Mm-hmm.
because I think until we redistribute, you know, equitably, social goods, resources, power, etc., um, the social determinants of health, we need to do that in order to overcome the history and the effects of these policies
Mm-hmm.
that have had on population health, particularly among groups that have experienced, such as the indigenous populations, that have experienced these negative impacts of these laws and these
Mm-hmm.
policies.
Mm-hmm.
Um, I mean, I think acknowledging is a start, and we've seen that happening in the university level. But I think it needs to go beyond that. I think we need to um, act upon, um, through our policies, in our interventions, et cetera, that we implement
Mm-hmm.
in order to achieve equitable health for all.
Mm-hmm. Mm-hmm. Okay. Um, okay, going back to your work. So, our students watched your short video about finding solutions through social epidemiology. And you mentioned how epidemiology is used to find solutions for health problems we have, and you alluded to this issue, and maybe you have already answered. But in lay term, like, can you explain briefly how you do that, how you apply epidemiological methods in social epidemiology?
Okay, so a lot of times interventions or policies are put in place, and there's what I do is I tend to that through my work is I evaluate the impact of these policies. So, for
Mm-hmm.
example, if a government comes in and we were going to raise the minimum wage, right?
Mm-hmm.
Because we feel it could benefit the population, especially people from lower socioeconomic status backgrounds. So, what I would do is I would collect data before and after this intervention has taken place, or get access to data that's already been collected. So secondary data analysis, and try to figure out or determine the impact of these increases in minimum wages. And this is just one example, right? And so, and see if it affects, health outcomes in particular. For example, what I've been looking at is mental health outcomes. Does it impact depression? Does it alleviate the burden of depression within populations that, where this intervention has taken place? That's one example. So basically looking at policies that hope to alleviate inequality, or even policies that could potentially create more inequality or inequity, and look at the effects of that too as well. Right?
Right. Yeah. So, you mentioned about your work looking at the impact of some of the social determinants of health on depression among adolescents. So, and there's an article about that, briefly explaining what your study is about. So, in that news article, you talk about how income inequality and neighborhood deprivation and lack of social cohesion in their neighborhoods being intertwined and intermingled with gender issues, and together contributing to depression, especially among girls. So it looks like it really bring home the issue of intersectionality and its impact on health. So can you elaborate a little bit more on that? Are you currently studying on that issue, on that topic?
Well, one of the studies that I'm looking at is income inequality amongst young mothers in Calgary, looking at income inequality within neighborhoods. From my previous research in the study that you cited, we found that income inequality, so the gap between rich and poor within a state, in one study, is associated with depression amongst women in the United States. So if a woman lived in a state where there was large gaps between rich and poor, they were greater of experiencing depression during a certain follow-up time. But we found that it wasn't significant among men. And some of the reasons that we discussed, what possibilities of why we found this or observed this finding, was that inequality affects women and girls differently than it does with men. So one way of looking at it is that among girls and women, they're more likely to internalize the adverse effects of inequality. So, and that results in depression. And in another study, we looked at aggression, and we found that income inequality, or the gap between rich and poor within neighborhoods, was associated with aggressive, so more externalizing behaviors amongst boys living in the Boston area. So we found that there was this differential impact of income inequality that is expressed depending on the gender. So amongst women, it was they tend to internalize, and then therefore there was depression, more likely to be depressed. And then amongst men or boys, it was more likely to externalize, and then you have some sort of, they're more likely to experience either being victims of aggression and violence, or being perpetrators of aggression and violence. And so you did mention the intersectionality. So intersectionality refers to how certain characteristics or population groups if they were to combine, they are more likely to experience, or the adverse effects of experience this inequality is exasperated. So if
Mm-hmm.
you're a woman from lower socioeconomic status backgrounds and you're a racial minority, the effects of the inequality is exasperated, or that it's more amplified. The effects of this inequality is amplified. And
Mm-hmm.
so you're more likely to experience, if you're a member of multiple groups that experience inequality or inequity, that these feelings or these inequities, these health inequities are amplified.
Mm-hmm. Yeah. So that's very interesting. And also I want to talk about the other article. So the title is Three Things That Can Make You Sick. And in that article, it is mentioned that what you eat and how active, inactive you are, whether or not you smoke cigarettes or you drink alcohol regularly or not, like you um are more susceptible to poor health. But it is also mentioned that there are other factors that could be more important and maybe out of your control, and those are the social determinants of health, right? So again, when we think about equitable allocation of investment and resources for better health for all, and when we think about interventions, which one should receive more money or receive more resources if you have to weigh that in? And I know the answer already, but I just want you to articulate on that.
So sorry, can you what are the two options again, would you
Yeah,
say?
so there are behavioral factors, right? Like
Okay.
physical activity, sedentary behavior, alcohol
Mhm.
consumption, cigarette smoking, and there are these social determinants of health, like
Right.
yeah, gender, race, ethnicity, SES, etc.
Okay. So upstream versus further downstream, right?
Yes,
And
yes.
so I think in Canada we do focus tend to focus on the behaviors, but we forget to understand is that or was often overlooked is that predictors of these behaviors are these social risk factors,
Mm-hmm.
these social determinants of health.
Mm-hmm.
So, for example, people from lower socioeconomic status backgrounds are less likely to be physically active. They're more likely to smoke, etc. So, if if we want to target these behaviors,
Mm-hmm.
a more effective way is to
Mm-hmm.
go further upstream and then address these social inequities in order to help create better health outcomes, or more equitable health, decrease the health inequities amongst populations that are more likely to experience these um, health inequities or social inequities or these behaviors.
Right.
Um,
So,
so I would argue is that if we want a more healthy population, we target the social inequalities or social inequities that are driving these health
mm-hmm.
disparities. And
Mm-hmm.
these include the health behaviors, right? And so
Mm-hmm.
I think a lot of times, policies are put in place without taking into the consideration the social inequities
Mm-hmm.
or the social injustice that is driving
Right.
these health behavioral and health outcome inequities.
Yeah. So these upstream factors like social determinants of health, they are kind of the root causes um, that
Exactly.
feeds into these behavioral factors
Hmm.
and make people sick or make people healthy.
Right.
Um, but you also mentioned that there is in Canada there is this public health narrative focusing on behavioral factors and intervening with those factors. Do you know why that happens? Why instead of targeting upstream factors?
That's a really good question. Um, I think a lot of times, people tend to blame the victim. It's easier
Mm,
to blame the victim or blame people who are participating or
mm-hmm,
taking on these, negative behaviors. Oh, the person smokes, so then he deserves what he gets for, or she deserves
mm-hmm,
what they get for smoking to get lung cancer, etc. And everything
mm-hmm,
like that. Which is ridiculous because it's more complex than that. Why people
mm-hmm,
smoke is a lot more complex than or participate in any negative health behavior or adverse health
Mm-hmm.
behavior
Mm-hmm.
is a lot more complex. And I
Mm-hmm.
think if we address, you know, further upstream, even start, when with children when they're younger, before these health behaviors take into effect, if we address the social inequities that you know we could help prevent um, people adopting these behaviors either later on,
Mm-hmm.
or in adulthood or childhood or whatever. So
Mm-hmm. Okay, so it sounds like your research, the things that you do, is no doubt very social justice oriented, and you use quantitative methods. So you look at things quantitatively and
mm,
using epidemiological methods. So can you elaborate on what that means? So, these are third-year undergraduate students, and
okay.
there is quantitative research and there is qualitative research realm. So when you compare that, and from the population health perspective, what are the benefits of quantitative research and looking things in a quantitative way, would you
Okay.
say?
So quantitatively, what I mean by that is, like, I take data from numerical quantitative data, like, so numbers, either
Mm-hmm.
through surveys or
Mm-hmm.
and link them with administrative data, so for, let's say, hospital data
Mm-hmm.
or mortality data or birth
Mm-hmm.
data. So, like, data that's there's data that's collected on the birth certificate or on death certificates, etc. All this is housed in Statistics Canada, right? And if I just apply to get access to this data, I could do some sort of quantitative analysis. So think of number crunching, to look at associations, to look at whether or not they be causal or whatever, to see if there are relationships between exposures of interest, such as the social determinants of health and health outcomes.
Mm-hmm.
This could be done, cross-sectionally, at one point in time or over time, just to see if there are associations, especially if you're looking at gaps in, if we don't know if there are gaps in the knowledge in Canadian, in Canada, for example.
Mm-hmm.
And so if you want to study, if things have been observed, or there's theories that you theorize, like, so for example, you think that income inequality or racial discrimination is bad for our health, which has been shown in other studies. How, if there's a gap in Canada, could I identify the data sources and then do quantitative analysis that way, and then look at associations or relationships between our exposures and health outcomes. That's one. This is pretty much what I do. Some sort of, using regression or analytical techniques, sophisticated analytical techniques, to identify or potentially observe these relationships.
Mm-hmm.
Um, so what was the second part of your question again?
Um, I think that was it.
Oh, okay. And what's the benefit, or
Right, yeah, like what's the from the population health
health
point of view?
perspective?
Yeah.
I think when it comes to numbers, it's easy to digest.
Mm-hmm.
So if you say, if someone who is poor, someone from a low socioeconomic status background, or someone who has no education, who didn't get a chance to go to university, is
Mm-hmm.
3 times likelier to smoke and therefore get lung cancer, or then 5 times more likely to get lung cancer in comparison to those who
Mm-hmm.
have come from a more wealthier background. These numbers are very easy to digest, and the impact is pretty, it's pretty clear, right? And so,
Mm-hmm.
if you look at, again, refer back to the pandemic, the the COVID pandemic, we could see that certain age groups are more likely to experience the adverse or more detrimental effects of the COVID infection
Mm-hmm.
than the younger groups or whatever.
Mm-hmm.
We also can see that people from it's been observed, but I think we need more data. Is that people from racial backgrounds, so people from um, in the United States, they observe this. They collect race data a lot better in the United States. So they've actually been able to observe that people from African American or Latino backgrounds are more likely to experience not only infection, but also experience negative adverse effects of being infected by COVID in comparison to white Americans. So when you see numbers, like say 5 times more likely or 3 times more likely, or they're less likely, if you could attach a quantitative number to that, it's very helpful. The impact or the message being sent across is pretty can be quite clear. I'm not saying it's the complete picture, but it could provide information or more knowledge that could help people try to explain why this is so. And why is it that people from minority backgrounds are more likely to experience adverse effects, right? So people might argue I've heard people say it's genetics, but no, it's because the health conditions that people that are put at greater risk, which include hypertension, diabetes, are more prevalent in populations from racialized populations in the United States, or in poor people who are from lower socioeconomic status backgrounds because they can't afford to, they don't have access to the social goods that leads to a healthier, more a better well-being sort of life.
So in essence, quantitative data provides something that are easily digestible, but also with clarity. So it can deliver clear messages, public-facing messages on important health issues, and really really highlight the impact.
Right. So if you say that, if you wear a mask, you're less likely to get COVID, then, there's usually a number or attached to it.
Right.
And that could help send that message, the public health message across, right?
Yeah. Right. Okay, so I just have one last question. So, many of our students will be in health professions after graduation. So do you have any advice or anything that you would like to convey to our students?
Oh, okay. So from a social epidemiologic perspective, I think one of the reasons why I'm a social epidemiologist is because I always sort of tend to gravitate or root for people that experience some sort of injustice. And it takes a lot to understand, not only to understand your one person's, lack of privilege, but to understand your own privilege too as well. And I think that's a huge step that, being university students, you have had the opportunities and the privilege of getting to where you are. And not everyone has those privileges. And so, as health professionals, I think understanding that could lead to better compassion, to those who you will be one day treating or working with or studying, etc., whether you're a researcher or a clinician. So I hope that's
great. Yeah, well, thanks, Dr. Pabayo, for speaking with us today.
You're welcome. My pleasure.
Okay.
So
Thanks.